Here we're going to look at a normal labor pattern for a patient in the obstetric setting. What we have right here is the fetal monitor, which is already on. There's a contraction showing on the screen with an acceleration in the heart rate. The contractions will be about every 2 minutes, lasting about 60 seconds. There will be occasional accelerations, as you will see. Now, fetal heart rates can change at any time, so you may see late decelerations, variable decelerations, early decelerations, or no accelerations in there. It's just kind of random, and it depends on each particular baby. When a patient comes into the obstetric setting, what we first do is put on the fetal monitors. When the baby is in vertex position or head down, the fetal heart rate is best found on the fetal back, which is typically this side or this side. As labor progresses, what we do is we turn the patient from side to side, in which you'll find the fetal heart tones typically in this area with the external monitor on either side, depending on which side they're laying on. One of the things that happens as normal labor progresses is that either the membranes rupture spontaneously or the physician ruptures the membranes. So that's what we're going to show you now, is the rupture of membranes. We're going to actually use an amni hook, like they would use in the obstetric setting. When this procedure is going to be completed, you want to make sure, first of all, that there is a chucks pad underneath the patient to catch the fluid. The patient's legs come up like this to make room. Typically the bed is lower to the floor, but this one is not. And so we'll just make do with what we got. The physician will rupture the membranes. They ask for lubrication. To do a vaginal exam, they check the cervix, which our patient is about 5 centimeters based on what's going on in here. And they gently insert the amni hook in which you'll see a trickle of fluid come out. And it's continuing to come out. And it will continue to come out throughout the labor process. You have to change the chucks pads fairly frequently in order to keep the patient dry. The other thing that you can do is take a towel or a washcloth, clean the perineum, and it helps, if you will use one, place a towel right here, that helps to keep the patient dry during labor. And you'll just neatly cover them back up. And there's so. Trash can in here himself. Alright, so I'm going to show you some different fetal heart rate patterns, just to kind of give you an idea of what they look like. I can get my little mouse over here. It'll take a few minutes to actually come on the screen, but what you're going to see is an early deceleration, and you'll notice you can actually hear the heart rate changing on the fetal monitor while you're here. Now, early decelerations are typically benign. It shows that the fetal head is coming down into the pelvis, and as the fetal head descends, you get compression, and therefore you get the deceleration of the heart rate with the contractions. So they look like, it's called a mirror image of the contraction. If these progress, the patient's early on in labor, some of the things you can do for that is turn the patient over onto their side, which we'll show you now. Always try to maintain the most privacy that you can. And this patient is very much a simulation of a patient with an epidural. It also helps if you can put a pillow between the patient's legs. We'll just scoot this one behind their back to keep them up on their side. But always making the patient as comfortable as possible. Remember, you have lines, you have tubes. Not to pull those out, you have to adjust those and move them with the patient. What's showing on the monitor right here are accelerations of the fetal heart rate. These are accelerations. These are early decelerations. They are a mirror image of the contraction. It starts to decelerate when the contraction starts. It gets at its peak with the peak of the contraction, and it's returned to baseline by the time that the contraction is over. The pattern that's showing now on the screen, here are the contractions still. These are called variable decelerations, and if you listen, you can hear the slowed heart rate of the baby. Variable decelerations typically indicate cord compression somewhere, whether it be a nuchal cord or the cord's just compressed up against the side of the uterus. There's several different reasons that you can have cord compression. And what we do for these types of variable decelerations is we would first of all change the patient's position. Turning them to one side didn't work, we would turn them to the other side. Most of the time they resolve spontaneously. What we're seeing on the screen now, the pattern is what we would call late decelerations. The characteristics of the decelerations are that they start, the heart rate starts to decelerate after the peak of the contraction, and then it returns to baseline at some point. This one is really a little better example of it. It slowly starts down, and the peak of the deceleration is after the peak of the contraction. Late decelerations are not good. What we would do for this patient is change their position from side to side, increase their IV fluids, and give them some oxygen. If those didn't work, the physician would evaluate whether the patient needed to deliver vaginally or needed a cesarean. So as the labor progresses, what they will do is routinely check the patient throughout the day. It depends on whether or not the patient has an epidural, the patient can feel pressure. So there's lots of variables that come with determining how quickly the labor progresses. Some physicians will check patients every 2 hours routinely. Some just wait until the patient shows signs. They see early decelerations on the monitor, things like that. For the most part, you won't find nurses checking patients every 2 hours unless they are ordered to do so. That increases the chance of infection when membranes are ruptured. So we're going to check this patient and see what she is dilated to. So we're going to uncover. Feet up like this. Let's get that out of here. Lubrication. The cervix is there. The baby's head has come down, it's rotated, and the patient's complete. So we're ready to start pushing with this patient. When the patient gets complete, one of the things that the nurses do is get the bed ready for the delivery. These are labor beds. They operate a little different than hospital beds. These have a mark on the side over here. The stirrups come up for the patient's feet. Patients who have an epidural, their legs are going to be a little bit more floppy than patients who have complete sensation. Our mannequin's pretty close to an epidural patient with her floppy legs. Out of the way, and then the bed lifts straight up and up. As the baby descends, we will ask the patient to push. Which they may give a grunt like that. Maybe not quite that long, you never know. Some patients do scream during delivery. The baby slowly descends down. The physician will help out just a little bit. You may see them put their hands right here. As the patient pushes, we would say, push, hold your breath, push, 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 as hard as you can. You'll see more fluid come out. You may see some pink tinged fluid come out. What the patient does is as she pushes, it's typically 1 step forward and about 3 steps back with every push until she actually pushes the baby under the pubic bone. And that's when you'll start to see the head crown and really give, whoop, Sometimes their legs get a little floppy. That's why we want to make sure we hold that up there. Alright, so you can see that the baby is crowning now. As the patient pushes, the head will start to crown even more. The physician will give support to the perineum so that the perineum doesn't tear. As the mom pushes, it slowly comes farther down and farther down. The physician may ask for some lubrication. Alright, as the patient continues to push, the baby slowly descends. Push. Push a little, there we go. Now we were going to say slow down. The physician's going to turn the head. He's going to use the bulb syringe to suction out the baby's mouth. And then each nostril. Then he's going to have the patient push again. And out comes the rest of the baby. The baby, as long as it's doing what we would place up on the mother's chest and dried with a blanket. The cord's still attached. The physician places the cord clamp on and clamps off the cord and typically allows the significant other to cut the cord. After the delivery of the baby, the physician will gently give pressure on the umbilical cord while waiting on the placenta to deliver. They don't tug on the cord. If they tug on it, they can pull the cord off of the placenta. The placenta typically delivers in that fashion, and you will see bleeding with the delivery of the placenta. This is the rough side of the placenta. There's two different sides. This is the shiny side. The shiny side has vessels. The shiny side is what's up next to the baby. The rough side is what's adhered to the uterine wall.
At this point, the baby would be on the mom's chest, being skin to skin. The mom's chest can keep her warm. You just lay a blanket over top of the baby while the baby's laying skin to skin. This is a great time to initiate breastfeeding at this point if the mom is wanting to breastfeed. A lot of times they're already exposed and the baby's right there, and they'll naturally gravitate towards the breast, but the baby will actually latch on, and this is a great time for bonding for mom and baby.